Hello and welcome. My name is Ruben Mesa, and I'm the Executive Director of the Mays Cancer Center at UT Health San Antonio MD Anderson. We're delighted that you have joined us for this interactive webinar on colorectal cancer. What do you need to know? I'm joined today by some wonderful colleagues and all key members and our faculty at the Mays Cancer Center. First, Dr. Randy Wright, who's Associate Professor of Gastroenterology and Nutrition. Dr. Tim Wagner, who's Associate Professor of Radiation Oncology. Dr. Laura Tenner, who's our Associate Professor in Gastrointestinal Medical Oncology. And Alicia Logan, Associate Professor and a colorectal cancer surgeon. So first, the most important part of defeating any cancer is ideally either preventing cancer, and we'll talk about that in our discussion, as well as if we have a cancer, finding it early. Indeed, in colon and rectal cancer, finding it early has become an incredibly important part of controlling that disease and being able to cure the disease. So with that, let me hand it off to Dr. Wright to discuss for us colon cancer screening.
Thank you, Dr. Mesa, for inviting me to talk this morning on something that's really important to me, colon cancer screening. Let's go to the next slide. So colon cancer is a very significant problem in the United States. Over 140,000 cases per year, with over 50,000 deaths per year, which is the #2 killer among both men and women of the cancers. And over the last few decades, we've actually done a good job at lowering those rates in people over about 50 or 55. But there is something new in happening in that younger people are getting colon cancer at an earlier at an age less than 50, and that has been a rising rate in the United States. So as Dr. Mesa mentioned, we want to, number one, prevent cancer, and colonoscopy is something that can prevent colon cancer by finding polyps, those growths that sometimes can turn into cancer. And when we find them and remove them, we can prevent cancer. There are also other colon cancer screening tests that are more of a early detection of cancer, so that we can find it at an earlier, more treatable stage. Next slide, please. So when should we start screening for cancers? Most guidelines in the United States for average risk people without any symptoms or family history of cancer tell us that you should start at age 50. The exception is for African Americans, because we know that they will have cancer diagnosed at an earlier age and at a later, less treatable stage. So the majority of guidelines have told us that we need to start screening African Americans at age 45. There are some other guidelines, in particular the American Cancer Society has said that we need to start looking at screening all races at age 45. That's not really mainstream quite yet. Some insurances are not quite on board with that, but because of the rising incidence in younger people, that may be something that we see in the future, where colon cancer screening may be offered at an earlier age. When do we stop colon cancer screening? Usually it's at age 75, especially for someone who's been up to date with their screening. In some cases, in healthy people, especially those who have never had colon cancer screening, it might be reasonable to screen all the way up to 85 years old, depending on your health. And if your health is good and it looks like you have about a 10-year lifespan remaining, there might be benefit to screening. I mentioned colonoscopy is the gold standard. It's readily available in our community, and it prevents cancer. For those who have been through colonoscopy, you know it's a big deal. You have to take a day off from work. There's an IV, there's sedation, there's an invasive procedure. But the advantages, as I mentioned, you prevent cancer by removing those polyps. And if you have a clean colonoscopy, you're good for 10 years. So, and colonoscopies are very safe. For those who are wanting to avoid that procedure, the next best test would be an annual test for occult blood called a fecal immunochemistry test. And this is a test that detects usually cancers at an earlier, more treatable stage. You have to do it every year. And you should know that if you have a positive test, that you would be required to go on to a colonoscopy. So some people would pick a FIT over colonoscopy. Next slide, please. And there's some other screening options a little bit down the list that you may have heard of. One is a CT colonography or a virtual colonography. Virtual colonoscopy is another name for it. That's a test that happens every 5 years. You do need to take a prep to clean out your colon. You will have a tube inserted to inflate your colon, and it's something that can miss flat polyps. And if any polyps are found, then you have to go to get a colonoscopy to remove them. The other common screening option is Cologuard, which is a FIT DNA, which includes some tests for genetic material as well as occult blood. And that's one that happens every 3 years. And again, if it's positive, you would be required to do a colonoscopy. So, you know, all these tests are options to talk about with your doctor, but just know that if you have a positive one, you got to go get a colonoscopy. Next slide, please. You know, I wanted to mention, since we're in the COVID-19 pandemic, the effect that the decreased screening rate has affected our society, and our screening rates are down by almost 90%, 80 or 90%, and especially in the early stages. And you know, we're worried about delayed diagnosis, increased deaths. I saw one model that potentially 10,000 extra deaths from decreased screening of breast and colon cancer over the next 10 years, which is a significant number of people. So my message to you would be that we have developed these procedures at our places where we do screenings to have you tested for COVID-19. We follow precautions. So it's very, very safe for you to come and get a colonoscopy or any other colon cancer test. And please do not delay getting your screening during this time. And the final message that I want to tell everyone is that the best test is a test that gets done. So if you're averse to having a colonoscopy, look at FIT or one of those other tests, and we will take care of you, but make sure you take care of yourself. Thank you very much.
Great. Thank you so much, Randy. Now, next, when a cancer is identified, there's potential roles of surgical care, chemotherapeutic drugs, and radiation therapy, either alone or in combination. So we're going to tackle each of these three in sequence. And during all this time, please be entering in your questions in the chat box. We look forward to taking questions as they arise. But first in that trio, let's tackle radiation therapy with Dr. Tim Wagner.
Hi, thanks, Dr. Mesa. Thank you for having me and letting me be part of this today. So let's say, you know, a patient goes through their screening or you know, is having symptoms and goes to see, you know, Dr. Wright, and we find that there's a mass, and instead of just being a polyp, you know, it turns out to be cancer. The next steps at that point, you know, essentially we'll stage the patient, right? So we'll try to figure out exactly where the tumor is, how big it is, if it's gone anywhere, and basically come up with a plan. So that usually takes place as part of a multidisciplinary tumor board, where somebody like myself and Dr. Tenner and Dr. Logue and Dr. Wright and the radiologist and the pathologist, we all sit together and try to formulate a plan, with how to tackle each individual cancer for each individual patient. So, the big three really are, in terms of how to treat cancer, you have, I'll put radiation first since I'm a little biased, but you have radiation therapy, you have surgery, which is essentially, cutting out the tumor. And then you have chemotherapy or systemic therapy, which is delivering medicine in an attempt to control or kill the tumor as well. Today, I'm going to be focusing on radiation therapy, which is, a unique type of cancer treatment that's been around for over a century now, and really, used in all different parts of the body, but has a special role in particularly rectal cancer. So for colorectal cancers, radiation mainly comes into treatment of rectal cancer, which is basically at the far end of the digestive system, right before you get to the termination. So for radiation therapy, what is it? I'll just start with a little background, because it is a little of an unknown or an uncertain topic for a lot of people. So radiation therapy is a type of cancer treatment that uses high energy beams like X-rays to kill cancer cells. For rectal cancer, we use a special type of radiation called external beam radiation. And with external beam radiation, what you have is, a patient will lie on a treatment table, and then you have an external source, an X-ray machine that generates high energy X-rays and pinpoints the delivery of that treatment to certain parts of the body. In this case, it would be the rectal tumor. Okay, and so it's a precise delivery of treatment. It doesn't require any invasiveness in terms of cutting or anything like that, and we're able to deliver hopefully a treatment that's going to kill the tumor and not cause too much damage at the same time. So the way radiation works is it damages the genetic material, which is kind of what you're seeing here over on the right. It's just a picture of a DNA, double-strand DNA helix there, and what you're seeing is the radiation, breaking apart that helix. And so what's happening is that genetic material that controls how cells divide and grow. So when these cancer cells try to divide and grow and take off and cause trouble, the radiation hopefully will kill them off. And while both healthy and normal cells are also hit with the radiation, the goal is to deliver enough treatment to the cancer cells without over-treating the normal cells. Then the normal cells, fortunately, have an ability to repair. So next slide, please. So why radiation? So as I was saying at the beginning, over half patients with cancer receive radiation as some part of their treatment. Radiation oncologist, will use radiation to treat almost every type of cancer. As I mentioned, with colorectal cancer, the majority of those that are going to receive this type of treatment are going to be the ones with rectal cancer. Radiation can be used for all different purposes, as Dr. Mesa alluded to. It can be the primary treatment for certain cancers. It can be used before surgery, which is called neoadjuvant therapy. So the bulk of treatment for rectal cancer is going to be neoadjuvant therapy. And the goal here is to shrink the tumor down so that it makes Dr. Logue's job easier when it comes time to take the tumor out. Sometimes we use it after surgery, and that's called adjuvant therapy. And that's to stop growth of any cancer cells that might be left after surgery. Sometimes we use it in combination with chemotherapy, which Dr. Tenner will get into. And in particular with rectal cancer, we use it routinely with a pill form of chemotherapy called Xeloda. And then in patients that have more advanced disease, so say the cancer has gone to parts of the body and is causing pain or bleeding or something like that, radiation can often be used to palliate those symptoms or help relieve those symptoms. Next slide, please. So how radiation works. So you come for a consultation with the radiation oncologist, and they say, okay, sounds good, let's do treatment. The next step is that you come in for what's called a simulation or a planning process. With that, you basically come into our department and we work, the radiation oncologist and the simulation therapists and the radiation therapists work to set you up for treatment on a daily basis. Basically, you lie down either on your back or on your stomach on what's called a treatment couch. We design molds and cushions to basically, immobilize you or hold you nice and still for the treatment. The therapist usually makes some marks on your body, and then we get a CAT scan to help with our treatment planning. So after the simulation process, I take the images and I define the target. So I look for where the tumor is, and I look for all the stuff that I don't want to hit with the radiation, and then I figure out how to aim the radiation beams. So I have planners that are called dosimetrists who then work with me to come up with this treatment plan. Once that's ready and we think it's safe to give, then we have a medical physicist that looks over the treatment plan and ensures that it's safe to deliver on the treatment machine before we ever actually turn the beam on. Okay, next slide, please. So for the treatment, what you see here on the right is a picture of a linear accelerator. So that's what's actually going to be delivering the x-rays. And the patient is going to be lying on that black board there, which is called a couch, not really any couch I would want for my home, but it's a couch, for the purposes of this, for this treatment, we call it a couch. And so on that couch, we do build molds that are comfortable for the patient so that they can lie still for 10 or 15 minutes during the treatment without moving and without being really uncomfortable. And again, for rectal cancer, oftentimes you lie on your stomach, but sometimes you lie on your back. But either way, we try to build a kind of a beanbag type device that holds you in place for your treatment. So what happens is once you get into that position, that machine will execute the treatment plan that we've designed, and it will deliver the radiation beams to the targets. So in this case, that's going to be the rectal tumor itself, and also the lymph nodes that are in the vicinity of the rectal tumor that may be harboring microscopic disease or little cells that we may not be able to see. Okay, so the beauty of the radiation is that it kind of goes through and through the body. The x-rays pass through the body and the patients don't feel anything. So we can get into those hard to reach places in the pelvis that are oftentimes difficult if you're actually trying to operate. For radiation treatments, the treatments are typically Monday through Friday, daily, okay, and they usually last about 15 minutes a day. For rectal cancer specifically, we've traditionally used a 5.5 to 6 week course. So basically you come in for 15 minutes a day for 5 to 6 weeks. Although in the last year, there's been more evidence showing that if we give a short burst of radiation over the course of a week, that may be as effective, if not more effective in certain cases. So if you come to see a radiation oncologist and they offer either of those two scenarios, they're essentially equal, but there's certain cases where we may use one over the other. Again, for the treatment, the patients lie still at that location, like I mentioned. The patient, once you're in position, the therapy team, once they have you set up, they step outside the room, and they have cameras and microphones that they can communicate with the patient. And then for the actual treatment, the patient just lies nice and still, and then treatment can be stopped at any time. Next slide, please. So during the patient's treatment, this is on the right here, just showing you here how the radiation treatments can be delivered to certain targets, and basically you can do what's called dose painting, where you really can give radiation to the lymph nodes and the rectum without over-treating structures like the bladder and the hips and other stuff that's important in the pelvis. During the week, though, you do visit at least once a week with your physician, and we'll go over how things are going at that point, because radiation can cause some side effects, and we want to be able to help you manage those as you go through the course of treatment. So some of the side effects are listed there. The common ones in this case: skin irritation, tiredness, usually a little rectal irritation, possibly some diarrhea, all things that can be managed, with weekly visits with your physician. Most of these side effects then go away in the weeks after treatment, and then basically after radiation is done, it continues to work for several weeks, and then hopefully once it's done working, you're ready for surgery, and Dr. Logue can go in and find that there's hardly any cancer left behind. So that's the goal. So that's just a little bit about radiation therapy and the main, how it's mainly used in the treatment of colorectal cancer, though again, each case is individualized, and we're part of the team and may function in different capacities depending on the situation.
Great. Thank you, Dr. Wagner. Next, the anchor is truly surgical cancer care for these patients, but particularly in certain areas where surgery is clearly the frontline piece. We're very fortunate to have Dr. Alicia Logue, who is one of our colorectal cancer surgeons and a key member of the Mace Cancer Center, to go over this. Dr. Loeb.
Thank you guys so much for including me. So just to give the basics, we know that colorectal cancer is the third most common cancer in the USA and the second most common reason for cancer-related deaths. Of course, this is very scary, and you wonder, is it genetic related? What can I do to reduce my risk of this? It's mostly sporadic. It's only about 1 in 5-ish people have any associated family history of either polyps or cancer. And only about 3 to 5% of them will actually have an ultimately identifiable inherited cause. One thing that scares the heck out of me, and I see it, about 3 weeks ago, I took a perforated cancer out of a 20-year-old person. It's rapidly increasing in people under the age of 50. We oftentimes will offer surgery for curative intents in people that don't have either locally advanced or metastatic disease. And to elaborate on that, even to this day, you always kind of wonder, if I can go for a cancer and get most of it, but not all of it out, is there a benefit? And intuitively, you'd think that's the case, but that's generally not true for GI cancers. So next slide, please. I think nothing better can articulate what we try to accomplish other than pictures. So some of these will demonstrate when we take a part of a person's colon out with the goal of it being curative cancer therapy. You can see that green articulates that in the slides. So we have a couple goals. In general, with colon cancer, so I'll differentiate that, and Dr. Wagner did a beautiful job about talking about rectal. So colon, basically, the best way I can describe it is the piece of bowel that is in the abdominal cavity. And if you think about where your bones are in the pelvic bones, it's really above that. When you really deal with rectal, the treatment protocols for that can be a bit different, but that really denotes the piece of large intestine that is encompassed within the pelvic bones. It's probably the best way I describe that to my trainees as well as patients. So we have a couple goals when you're really talking about intra-abdominal colon cancer, which is kind of a fancy way of saying the large intestine in the abdominal cavity. You want to do a couple things. Surgically, you want to make sure that you can get all the disease out. There's not disease in other parts of the body that can't be removed. Sometimes, unfortunately, when our patients present to us, they may have multiple tumors in the lungs or liver in which you can't take all that out. And if you can't remove all of it, you haven't really done somebody a favor, and that can be a difficult thing. So with a true intra-abdominal colon cancer, the goal is to remove the section of the bowel with 5 centimeters of good tissue both before and after the tumor. So say you had a tumor in the first part of the colon, you want to get the 5 centimeters before and after. But then you think about, how does colon cancer spread? We'll do that through both lymphatics as well as hematological, which effectively is through the bloodstream. So you remove the bad part of the bowel as well as the blood supply or lymphatics of that. And the intent really is to hopefully stop it in its tracks and then be able to reconnect the good bowel to good bowel. So next slide, please. So this is another, and I always think, well, what is the best way if I was trying to learn about this, or if I was a patient and wanted to be able to make the best decision to understand my risk of surgery, what exactly is going on. So I like this diagram for that reason. So the goal is, get rid of the bad stuff and get the good pieces of bowel connected back together. This is one of the most typical operations where we would remove a part of the distal or sigmoid colon, and this would denote where the tumor is. With that would include the blood supply and lymphatics, and then the goal is to bring healthy tissue to healthy tissue. We do a handful of things that ensure that heals appropriately. There are several factors that play into role of, if I take a piece of your bowel out and I connect good stuff to good stuff, will that work for you? And that's called an anastomosis or reconnection. If you're malnourished, meaning that a person is maybe very sick chronically from, sometimes the cancer in itself can do that, or other chronic health issues. If somebody smokes, if they have poorly controlled diabetes, or they're on other sorts of immune suppressive medications like a steroid, that may mean that their ability to heal this sort of reconnection, meaning I take the bad stuff out and I reconnect the good things together, will that heal in the first couple of days to the point the stool's not going to go someplace that you don't want it to go? That's called a leak. So you can see here we call it anastomosis. And you know, older I get, I honestly think I've gotten to be more nervous and conservative over the years, and which I think is probably good. But one of the things that keeps me up at night is the prospect of an anastomotic leak. And I think about all the things that I can do to help prevent that. We do several things intraoperatively. We actually use a special device in which we inject a dye that allows us to use a fluoroscopic tool to discern whether or not the blood flow to the colon is sufficient. And that to me is one very correctable issue surgically. If the blood flow is not good, then well, at least I know that in the OR, and I could, you know, remove the piece of colon in which the blood flow is not adequate, and you know, brings good stuff back together. There are other things that may play into role about whether or not a person should be reconnected or have an anastomosis versus an ostomy bag. And that's probably one of the most typical things I hear from my patients is like, well, do I have to have a bag? And I've believe very strongly with what one of my mentors told me now going about 13, 15 years ago when I was a resident, along the lines like, you don't ever electively take a tumor out of another human being or do a major operation without looking in the whites of that person's eyes at least twice, because this is a tremendous shock to hear. While you have cancer, you have to have a piece of your bowel taken out. These are all the good and bad things that potentially can happen, or what the goals are. And I appreciably that's a shocking thing to hear, even in a person that's medically very articulate. So I like to talk to people and get to know them a little bit, especially when it can be done in an elective setting, and that make sure that they're understanding what's going to happen, and then ultimately the goals are very clear. And I've thought about ways to articulate this, and the prospect of, if we go in and do surgery, it's unusual to have a situation in which we would not anticipate the prospect of giving somebody a bag. And that's probably the biggest thing I hear from my patients of, I don't want an ostomy bag. I don't want poop to come out in my side. And I will always make that very clear to somebody, that certainly is a possibility. Although for elective surgery in general, and if it's a person who has a good immune system, there's not radiation involved, they're otherwise in pretty good health and don't have a lot of modifiable risk factors. If you have to have surgery for colon cancer, generally that can be accomplished safely with being able to remove the bad part of bowel and put you back together without a transient bag. And even to have that usually means just a couple months. It's pretty unusual that sort of thing to be permanent. So next slide, please. And so some of the things that I'm super enthusiastic about, and again, with age, I think you appreciate the good and bad things of, what can happen to another human being surgically. And I do a lot of laparoscopic, and that probably reflects there in which I was trained. I know how to do robotic as well as open surgery, but I like laparoscopic the best. I think it's very fast and efficient. And, we have a system down that's really pretty good. And the people at University Hospital are really familiar with that. So some of the benefits from the patient standpoint is I can go in and do the goals that we talked about, specifically moving the part of the colon around that needs to be taken out, as well as the blood supply and the lymph nodes, through incisions that effectively are 5 to about 15 millimeters in size, which are really pretty small. I think about that, it's just a little bit over a centimeter, even in the biggest site. But then you think, well, I could move that bad part of colon around. I can prepare myself to take that out, but ultimately I have to remove that from some part of the person's body. So we usually make about a 6 centimeter incision. And this picture denotes, sometimes it's down below the belly button, or it can be over here, in which we do all, free everything up, and then ultimately take the bad stuff out and put the good stuff back together. This is an ostomy. One of the things I've become tremendously enthusiastic about in my practice is being able to understand what these things mean before it's on your body and it's a painful postoperative issue, meaning I've had a major abdominal surgery myself, and I know what it feels like to wake up and your body hurts, your muscles hurt. That certainly isn't the time to really understand from an educational standpoint what bags or drains or anything else mean. So we do try to make sure our patients understand that if you're going to have a temporary ostomy, to let stool leave the body before it travels by an area that's reconnected and maybe somewhat slow to heal. What exactly does that mean? What does an ostomy look like? You look at that, I mean, to me, it looks like a kind of a rosebud of some sort, and you put a pouch on it. We do send our patients to an ostomy therapist, and some of the purpose of that is, I don't want you to wake up in shock. I want you to understand what it means to put a wafer in a bag on, how you take care of the ostomy, and I think the best way to learn that is before your body's in, post-surgical pain and obviously the shock going through something like that. But then the other thing that our ostomy nurses do, and at UH, they're, in my opinion, they're wonderful at it, is they'll look at spots where if a person has to have a temporary bag, and again, this is unusual for something like this to be permanent, where does that fit best with your clothes? That can be a total game changer based on a person's body habitus and where their belt buckle comes up. Make sure it's in a place that's not going to be a total nuisance. Do they, is there any problem with the person's hands? Do they have arthritis or inability to see, to take care of that? Who's going to help them do that? So meeting with the ostomy therapist is a resource that we have that I think is tremendous, and certainly something I'm very enthusiastic about. So next slide, please. And this shows the difference. It's interesting how I think with experience and thought and age that you think the very, very best thing I could do for another human being who entrusts me and absolutely gives me the privilege to let me operate on them for cancer. Every day when I walk into work, I think about that. I'm like, somebody thinks enough of me to do this, and that's a blessing and a very positive thing. I have to do the absolute best operation that I know. And that I can do. And oftentimes that can be accomplished laparoscopically. Sometimes it can't. And it may be that tumor is in a location in which it's stuck to other structures. And when I do colon cancer surgery, I think my number one goal is I cannot leave anything behind. If I do that, if the margins are closed, I mean, specifically if the tumor is stuck to other structures and I leave tumor cells behind, I have not done you a favor. That sort of tumor has a 50+% chance of coming back with a bang. And when that happens, that's a tremendously difficult thing to palliate or treat. So whatever operation I can do for a person to get all of that tumor out and not leave anything behind is what I do. And probably, I would say 75, 80% of the time that can be accomplished with a minimally invasive technique. Sometimes it can't. And if I, think about it and think, gosh, the prospects of being able to accomplish the absolute best cancer operation for that person, it's not going to happen with a minimally invasive approach to get a bigger cut. And that's certainly it's a bit more painful and difficult to recover from, although long-term results are pretty equivalent. It may mean that you're in the hospital for an extra day or two and that you may have a couple more weeks of recovery. But my thought is long-term, I want that person to absolutely have the best benefit oncologically. So that may be why we end up with an open operation, because I feel that the issues in regards to a post-operative recovery from a large incision are much less problematic than in that adequate cancer operation. So that's always our goal. Next slide, please. And I suppose that's it. So I'm happy to answer any questions.
Well, wonderful. Well, that was a wonderful description of the options and what people go through with this surgery. And again, as folks have questions, please be putting them into the chat box. Now, the third leg of the stool, if you would, as we try to treat colon cancer, is our medical therapies. And although we put them under the quote umbrella of chemotherapy, as Dr. Tenner will tell you, they involve many other aspects of medicines that are used to treat this disease. Dr. Tenner.
Thank you so much, Dr. Mesa, for having me today. This is one of my favorite things to talk about, so I'm really excited to be here and chat with you all about basically the things that I do every day with patients, which is talk about therapy for colorectal cancer. So I want to break it down into 4 different areas. We're going to start out by talking about some chemotherapy in colon cancers after the surgery. So oftentimes chemotherapy is used then. We're going to talk a little bit about chemotherapy in rectal cancers, which you've heard a little bit from Dr. Wagner, is used at the same time as radiation or after radiation. We're going to talk about different types of therapies when cancer has moved to other locations besides the colon. So we call it metastatic when it's gone to places like the liver or the lung or the bone. And then we'll talk a little bit about some side effects of some of the more common chemotherapies that we use. So you can hear a little bit about maybe what you or some of your loved ones will be going through. Next slide. So first of all, let's talk about chemotherapy and colon cancer when the cancer is local. What does that mean? So when cancer is contained within the colon and the surrounding lymph nodes, and usually the cancer will be found by, for example, Dr. Wright when he goes in there to do the screening colonoscopy, and he finds cancer and he says, "Hey, Dr. Logue, I found cancer." And then the patient goes to Dr. Logue for a surgical resection. And then after that, we look at the tissue under the microscope to try and decide whether I can help out in the setting of giving chemotherapy. And oftentimes, if cancer is moved into some of the lymph nodes surrounding the colon, we would recommend chemotherapy after surgery. So the chemotherapy is typically given for about 6 months after surgery, sometimes 3 months if it's a lower grade cancer. And the chemotherapy is typically given every 2 to 3 weeks. In general and all over the world, they're the same chemotherapies that are given, and you'll see these two little nomenclatures called Folfox or Zalox, and they describe a combination of 2 drugs. If you could click once, Dr. Mesa. So if you were to use Zalox, for example, one of those drugs comes in pill form, and the other one is an IV form. One more click, Dr. Mesa. If you were, however, to use Folfox, both of those drugs would come in that IV form, and one of them actually has to be given over 2 days in a pump. Okay, so there are different options to choose from and different therapies. They're both equivalent, and we can talk through those different options depending on what fits your lifestyle better. So those are some things to consider. Next slide. In the setting of rectal cancer, we actually have a little bit of a different treatment options, and this is what Dr. Wagner had discussed a little bit in his talk, where we try and do some upfront treatment to try and shrink the tumor. One more click, Dr. Mesa. In this setting, we use radiation up front to try and shrink that tumor, and I'll often give chemotherapy in addition to that radiation and at the same time as that radiation to try and make sure we can shrink that tumor maximally. So when our surgeon, Dr. Lowe, goes in there to remove the tumor, we can actually get good results and make sure that we have curative intent for that and remove all of the tumor. The pills are typically given on the same days as radiation, which is typically given Monday through Friday. So you'll take those pills every day, Monday through Friday during the week, and then you're off Saturday, Sunday for the duration of that radiation. If, for example, there was a holiday during that time period on a Monday and you didn't receive radiation on that day, then you would not take the pill that day. You only take the pills on the days of radiation. And that treatment is typically for about 6 weeks. And as Dr. Wagner already discussed, within the last year or two, there's been some alternative options to maybe doing some upfront radiation for a shorter period of time and then following with chemotherapy. The caveat to that is when you follow up with chemotherapy, you have to add an IV medicine to it. So it no longer is just the pill. And so these are different things we can weigh in the pros and cons of which option to choose in therapies of patients. Next slide. But where chemotherapies and other IV therapies take the largest role probably is in the setting of metastatic disease. So when cancer has moved to other locations like the liver or the lung or the bone, we have to treat multiple locations at the same time. And oftentimes the best way to do that is to give medicines that go into the bloodstream so that they go anywhere the blood goes, and they can attack chemotherapy at different locations all at once. For the most part, we use chemotherapies for that, some of the ones I've already discussed as well as others. And chemotherapies are effective in about 80% of patients, which is actually pretty exceptional for chemotherapy. We also have some other options called directed therapies. What do I mean by those? Well, they're antibodies, monoclonal antibodies that are produced to target a particular mutation. And so what we can do is we can actually sequence out the tissue of the cancer and look to see if it would respond to some of these directed therapies that we have. And about 40% of colorectal cancers, they have mutations to make things like the EGFR inhibitors not helpful. But in about 60% of patients, we can use some of these directed therapies. And these, of course, give us an extra tool in our armamentarium to be able to fight cancer. And then, of course, I'm sure you all have seen the commercials on TV for the amazing immunotherapy. And you probably heard about it used in lung cancer and melanoma and renal cancers, and it has been touted as the new cure-all. Unfortunately, in GI cancers, it isn't effective with the exception of about 5 to 10% of the population. So if you remember in Dr. Logue's talk, she talked about some types of mutations that are passed down from family to family. And one particular is called Lynch syndrome. And in that syndrome, immunotherapy is exceptionally effective. So we can get curative intent therapies, oftentimes even in the metastatic setting. But that's only in about 5 to 10% of the population. There are some people that have sporadic mutations, meaning they just happen by chance, that mimic the Lynch syndrome, that have not been passed down from family member to family member, and those still are, immunotherapy is still effective in those instances. But for the most part, again, that population is only 5 to 10% of people. But if you are lucky enough to be one of those 5 to 10% of people, then there's a very effective therapy for you. And of course, we are always looking for new agents, and so we have lots of clinical trials, and we're always trying to find new and better things. So those are always an option for people as well. In about 20% of metastatic colon cancer, we can actually cure the cancer, oftentimes by working together with radiation oncology and surgical oncology to be able to either remove the tumor or to radiate it. And we also work with our interventional radiology colleagues to do fancy procedures like transarterial chemoembolization or TACE, or radiofrequency ablation, RFA. And so even oftentimes in the metastatic setting, we can be very effective with these therapies in addition to our chemotherapies and directed therapies. Next slide. I just want to cover a couple of side effects. And these, I'm just picking kind of the most common drugs that we use to talk about some of the side effect profiles. And this is what you would do with your medical oncologist if you were planning for treatments. So for example, FOLFOX and CAPOX, the two things that we talked about during this talk, common side effects to that could be things like mouth sores and diarrhea and hand-foot, where you get redness of the hands and the feet and some peeling of the skin. And when those side effects occur, typically we dose reduce and those go away. So they're very manageable. Oxaliplatin has a little bit more of some side effect profiles we have to keep a close eye on. One of them is cold intolerance, and that's just annoying. It will go away after a while, but for the couple of days after you get that infusion, if you stick your hand into a refrigerator to grab something out of it, you'll get a little bit of a shock, okay? Any kind of cold you touch will be a reminder to you that you should not touch cold things. That usually only lasts a few days after the infusion. You can get nausea, but we're pretty good about pre-treating that. So we have a lot of things to help with that. But the main one is what's called neuropathy. It's numbness and tingling of the hands and the feet. And that one is the one we really have to keep a close eye on, because if it gets too bad, even after stopping oxaliplatin, it can stay around, okay? So you work really closely with your medical oncologist to follow that neuropathy and make sure it doesn't get too bad. We also watch kidneys and, of course, watch out for fevers. Next slide. So we've talked a lot about combinations of therapies with radiation, chemotherapy, and surgery, and I'm going to turn it back over to Dr. Mesa to see if there are any questions we can answer for you all. Thank you.
Wonderful. Well, it's been a great discussion so far. I really appreciate all of the talks. Anyone with questions, please go ahead and put them into the chat box. While we're waiting on those, first, let me throw out a question for Dr. Wright. So this year we had, sadly, we lost a great cultural icon in Chad Boseman to colorectal cancer, and he was very young and in some ways would have been younger than the typical screening age that we're familiar with. Maybe make just a couple comments on one, why we think there's greater risk in African Americans, and two, how we would try to factor in other factors in terms of when to start that screening.
Right. So I know that the actor Chadwick Boseman was, I think, around 40 or 39 when he was diagnosed, which is a little bit younger than even the guidelines for African Americans that I mentioned in my talk at age 45. I think the important thing to remember is that you have to pay attention to symptoms. So if you're having concerning symptoms like rectal bleeding, changes in your bowel habits or your bowel caliber, abdominal pain, something that's new, that's something that potentially should be investigated. So talk to your provider, talk to your physician about that to see if a diagnostic test is appropriate. As far as why African Americans are, more at risk, I don't know, the completely why. There's some multifactorial thoughts about discrepancies in access to healthcare, but they are more likely to develop cancer earlier, and so those guidelines were all pretty universal to recommend screening them at age 45. Does that answer your question, Dr. Mesa?
Yes, no, that's very helpful. Dr. Loeb, patients frequently will ask me, well, what more can I do to prevent the disease? And clearly there's a lot of things out there in terms of diets or others that claim they're good for kind of gastrointestinal health. Any thoughts or suggestions in terms of what folks should be doing in terms of diet, exercise, supplements, or others for both their overall colon health, but to try to decrease their risk of colon cancer?
That is a great question. One thing I tell people is we believe that fiber is to some extent a detox. So most women and men need about 10 grams of fiber in their diet a day. Women need 25, men need 30. If realistically you're not eating fruits and veggies, that's okay. Metamucil is a wonderful supplement. The way that comes now is very palatable. But that being said, if you don't like to mix Metamucil and drink that, that's totally fine. You can get fiber gummy bears. When you go to HEB or CVS or any random drugstore, you can find them in the same section that you would find Fibercon or Metamucil, and each gummy bear is about 4 grams of fiber. So I tell people supplement that appropriately. It's really interesting. So in regards to young people getting colon cancer, that's something I'm tremendously enthusiastic about, because one of my friends from medical school was the picture of health, strong, young, healthy, beautiful, all the good stuff, and got diagnosed at stage 4 at 33 and died at 39 several years ago with 0 risk factors whatsoever. And at the time that seemed shocking to me, but then the more I see it in my practice, it's very much increasing in the young. A couple points I wanted to make in regards to that is, if there's anything that seems off, if it's stomach pain, rectal bleeding, I would rather a patient come to me and say, hey, listen, just something doesn't feel right. We can work that up appropriately. I know Dr. Wright probably echo this, the threshold to do some level of testing or colonoscopies, very low if there's any concern of that. And, I do clinic every Friday and every other Monday, and I probably see at least 10 to 15 patients a week that the referral is for rectal bleeding or hemorrhoids. And, sometimes depending on the symptoms they describe, we'll offer some additional workup or colonoscopy when they're under 50. And about 1 or 2 times a year, we'll get somebody in who had, really pretty benign symptoms of things that you think, I could totally see how that's just hemorrhoids. There's not really a significant risk, but maybe 2 and 2 didn't quite equal 4 on that. And we offered a colonoscopy and found that, significant cancer in someone at the age of 50. So certainly don't be embarrassed when a person comes to us. We keep those, visits very confidential and discreet. And I know it's a really uncomfortable thing to have. In regards to further health issues that we may be able to do to present that, there's lots, prevent what, getting colon cancer at a young age. There's a lot of theories about that, one of which is called the church theory, and that comes from a colorectal surgeon at Cleveland Clinic whose interest also is colon cancer in the young. And his theory is, why is the incidence of colon cancer in people that are born after 1990 dramatically increased compared to what it was 50, 60 years ago? And a lot of it is because is our lifestyle that much more sedentary? Specifically, we have jobs or lives in which when we feel like we have to go to the bathroom, we don't immediately evacuate. So does that prolong the amount of time in which the colon's exposed to the toxins of stool? Some of the reason why his theory works is that colon cancers in people under 50 are almost always distal, meaning it's the last couple feet of bowel rather than the first few. So the thought process is because of our lifestyle adaptations, are we holding stool in when we shouldn't? And is that exposing the mucosa to toxins that ultimately put the person at higher risk for developing cancer? So I don't want, again, I'm somewhat reserved. I don't want to be crude or anything, but my point of that is if you feel like you have to go to the bathroom, don't hold it. So
Great. Well, that's very helpful. And indeed, there is a question regarding, and I know you've mentioned several, but thoughts from yourself or other panelists really about early symptoms of colon cancer. I think that's really a key part that you mentioned. You know, all of the discussions that Dr. Wright had regarding screening are in people that have zero symptoms. Anyone who has symptoms, and I, like yourself, I lost a dear friend who died of colon cancer at age 18.
wow.
And it was unexpected. But again, there's many inflammatory conditions and other things in the colon that can completely change the dynamic. But other symptoms, particularly that, again, now during the COVID pandemic, people have been more reluctant to receive medical care, which, you know, fortunately, I try to dissuade them of that concern, and that I think probably one of the safest places you can actually come during this time is into our medical center. But thoughts on other early symptoms? Dr. Wright, anything we're missing there?
No, I think that to echo what Dr. Logue said, the rectal bleeding, do not assume it's just hemorrhoids. If that's something that's been going on and you've, that needs to be looked at. Iron deficiency, especially in young men. Abdominal pain, especially something that is new or associated with a change in the bowel habit, something is different, weight loss, those kind of things in any age. A young person, don't just assume that it's something that will go away. You know, get it looked out. Many times, really most of the time, it could be nothing. But you really need to have those checked out. And as Dr. Mesa said, our places are safe to go to. You know, one other thing I wanted to point out along the lines of risk for cancer and why young people are getting cancer, we have an obesity epidemic in our society. And we know that obesity increases your risk for cancers. Diabetes is another thing that can increase your risk of colon cancers. Those things are in many ways modifiable. So you might be able to lose weight or control your diabetes. So there are some of those things in addition to the fiber and the fruits and vegetables and the diet. A diet with high processed foods, red meats, that's another thing that can increase cancers and can be modifiable. So those are things that you can do today to reduce your risk of colon cancer.
Wonderful. Let me ask Dr. Wagner a question. You certainly described eloquently, you know, the ways in which radiation can be harnessed to treat a colon cancer. Now, I know that in society there can be great fear sometimes that casual exposures to radiation from screening at the airport or from a chest x-ray or others can increase our risk of cancer, even mammograms. Just want to give a sense to folks, any need for concerns regarding kind of routine exposure to radiation in the medical setting or out in the community?
Yeah, so great question. And I think, you know, you're right. In theory, you know, any dose of radiation can, in a tiny percentage of patients, increase your risk of developing a second malignancy. But when used for, you know, diagnostic proven purposes, you know, it's all risk benefit. All this stuff that we're talking about today is risk benefit. So, you know, the potential benefit that you get from detecting, you know, an early stage breast cancer or something like that through imaging, you know, as opposed to letting it become more advanced and potentially metastasizing with a tiny bit of radiation from a mammography, clearly swings, you know, in certain populations that are recommended for mammography, you know, clearly swings towards actually, you know, doing that diagnostic procedure or in that case, you know, screening procedure. And similarly, if you're having symptoms that say warrant the CAT scan, you know, the small amount of radiation that you're getting from that CAT scan, you know, the risk of that procedure compared to the potential benefits of uncovering something that may be, you know, potentially life-threatening, again, swings into the balance of going forward with the procedure. Now, you know, back in the old days, they used to have these X-ray machines to see if your feet fit in shoes and stuff like that. So that kind of exposure, I mean, the risk-benefit, well, you know, it's probably better to have shoes that are a little bit too tight than all that extra radiation, right? But when you're talking about, you know, symptom management and trying to get to the answer of something that's an unknown, you know, definitely we're talking tiny risk, but, you know, over the course of millions of people, that's where you start to see a couple of numbers. But again, compared to the benefit, we advocate for screening and diagnostic procedures as recommended in our guidelines.
Wonderful. And final question I'll direct toward Dr. Tenner. Now, all of you working together can lead to a path where individuals can be cured from their colon and rectal cancer with a combination of everything that we've discussed. And this puts individuals in an important group that we call cancer survivors, individuals that have gone through a cancer journey, and now hopefully the cancer is in their rearview mirror. Now, there are many things we've learned about that journey and how to help someone really recover the best after a cancer, as well as what to do in the future. Laura, want to give us just a few thoughts on what does it mean to be a colorectal cancer survivor?
Yeah, absolutely. Thank you. We get to walk with patients through their treatment journeys. And then once their active treatment is done, meaning that they're done with chemotherapy and radiation and surgeries, then the next portion of that is what we call our survivorship screening and surveillance. And basically what we're doing is we're following along with you and continuing to watch to make sure that that cancer doesn't come back on us for whatever reason. And part of that includes surveillance, including repeat colonoscopies, which I know are everybody's favorite, and imaging modalities. But it's also following up with you in clinic to make sure that new symptoms, addressing new symptoms, and looking at different things that may pop up as you go through. A lot of the discussions that we'll have in clinic about what to do best with moving through survivorship is kind of readdressing the way that we live our daily lives, looking at how we can incorporate more exercise into our day-to-day, and also looking at some of the foods and the things like that that we eat. As Dr. Wright and Dr. Logue have been talking about, we try and increase fiber, we try and increase fruits and vegetables, we decrease our red meat intake, we try and increase some of the tree nuts, right? So anything but a peanut, okay, those have been found to have some benefit in preventing recurrence of colorectal cancer. So there are some things that we can do in terms of both what we include in our diet, as well as how we do exercise on a day-to-day basis that can help in our survivorship path and journey. And we typically follow along with people for about 5 years. And the further you get away from that surgery and that active treatment, the less likely it is for that cancer to come back.
Wonderful. Well, this has been a fantastic discussion. Overcoming cancer takes a team, and we're incredibly proud of the passion, the commitment of the team of hundreds of physicians, nurses, and scientists at the Mays Cancer Center at UT Health San Antonio MD Anderson, your National Cancer Institute designated cancer center for San Antonio and South Texas. It's been wonderful that we've had a chance to hear from just some of the members of the wonderful UT Health San Antonio MD Anderson colorectal cancer team. We hope that this webinar has been helpful. It's part of a series as we'll be discussing both additional cancers in the months to come, as well as other opportunities and topics of interest for those who either face cancer or are cancer survivors. With that, deepest thanks to our panelists, and everyone stay well. Thank you.